So thank you everyone for attending the next case conference for the Missouri Antimicrobial Stewardship Educational Collaborative. My name is Mike Durkin. I'm an IV physician and the co-director of stewardship at Barnes-Jewish Hospital. And then with me is Erin Rochmeal, antimicrobial stewardship pharmacist with extensive experience with community hospitals, who also works at WashU. Kevin Hsueh, who normally helps lead these, is at a conference this week. Next slide. So neither Erin nor I have any disclosures. Next slide. So this is an interactive session, just like the others. This is just a test to make sure that our Poll Everywhere software is working. So for those of you that are attending, please log into Poll Everywhere, make sure that the system's working for us. Great. It looks like we've got plenty of responses. Next slide. Just some updates. Please, if you have any questions at all, email us at mo.stewardship@wustl.edu. We would be happy to try to answer any difficult stewardship questions that you have. We usually review those Monday through Friday, and typically we'll answer you within a couple days. If we don't know the answer, some of our colleagues that are experts in transplant infectious diseases or fungal infections or other things help us out from time to time too. We've listed a few reasonable topic examples, and then I'd also like to highlight one-on-one stewardship consultations too. So we've had several pharmacists talk with Erin, and I think we found it to be a beneficial experience in how to modify our educational collaborative program. It also gives feedback to our funders, including the state and the CDC, showing that this program is helpful for you guys too. And you might get a few useful pointers from Erin about how to potentially improve your program. And then lastly, I think of the people that so far have participated, it's been a little bit of a therapeutic session to complain to people about their stewardship programs and some of the issues that they're having at their local hospitals, which is completely fine too. We're always happy to listen to that and give you some free cognitive behavioral therapy counseling.
Yeah, and I'll just add that I really enjoy learning about the programs and learning about what you guys are doing and hearing about where you're struggling. You know, a lot of times what I'm hearing is other people are struggling with the same things that I struggled with, but also hearing about your successes and how you overcame those barriers, any barriers that you had to achieve those successes. And it's helpful, really helpful for us to learn what different hospitals are doing and how they're doing it. It just helps us better understand what's going on out there. So I really enjoy those conversations, and I hope you guys find them useful too.
Yeah. And anything that you found successful at your hospital, we'd love to share and try to disseminate as well. Next slide.
Oh, hang
on. So here's our example case discussion. Today we've got a 28-year-old obese woman who presents to the hospital from home complaining of abdominal pain for several days. It abruptly worsened in the last 12 hours. In the emergency department, she's febrile but has stable vital signs. She has a white blood cell count of 16,000 with left shift. She's obese, as discussed there too. They did a CT of her abdomen because of the abdominal discomfort, and they identified a ruptured appendix with a fairly large abscess. The emergency department doctor starts her on vancomycin, pip-tazo, and then IV fluconazole, and admits her to the floor. So the hospitalist is then seeing her and continues the antibiotics. So we'll think about some of the case discussions and opportunities and other things related to this case. I'm sure several of you already have additional ideas too. So next slide. please comment on what stewardship issues you see here. Yeah, is there a need for an antifungal? That's a great question. We'll talk about that later. Vanco dosing inappropriate, fantastic. I think these are all great questions. I think whether or not they need vancomycin is a useful one too. This person's coming from the community, so they might not need vancomycin. We'll discuss a little bit about why potentially vancomycin is used too. Any other comments? We'll kind of stick with those, I guess, for right now. And we're going to discuss them a little bit more on the next slide. So, next slide. So, choice of agents. A lot of people we had some people questioning whether or not antifungals are needed. For community-acquired infections, antifungals probably aren't needed. Typically, if they are used, we're usually worried more about patients with significant previous antibiotic exposures or healthcare-associated infections or upper GI-related issues rather than lower GI with antifungals. And oftentimes, the kind of cannons would be used instead of antifungals with an azole too. So I think those are all great points. At this point, with her being pretty sick and everything else, an IV agent makes sense with this ruptured appendix and everything else. But later on down the line, if nasal would be considered and she's stable enough to take oral, the bioavailability of fluconazole is excellent, so that would be a consideration too. The vancomycin is kind of an interesting choice. At our hospital, I feel like that's kind of a reflexive antibiotic selection. If someone's sick, they'll use vancomycin and Durkin, or vancomycin and cefepime and metronidazole. I'm not sure if that's your experiences too. Erin, what are your thoughts? Is that kind of a common combination that you'll see?
I think so. At the other institutions where I've been, it was really common to see vancomycin just added on when someone was sick without a lot of real thought about it.
Yeah. So
and often added on at the dose of a gram Q12 too, without a lot of thought about that either.
So vancomycin, we usually are thinking about vancomycin for MRSA-related infections. For intraabdominal infections, the only thing you're really picking up for it that would be common in a community-acquired setting would be enterococcus. And most of the enterococci should be covered by piptazo too. So Durkin has the penicillin in it, so it should actually have reasonable coverage against most ampicillin-susceptible enterococci. So if when you're approaching the physician and asking them why the vancomycin's on, if they mention enterococcus, you could probably say, you've got pretty reasonable coverage with the piptazo, or you could even argue in a community-acquired infection that you might not need enterococcal coverage too. So I think those are some of the great points that we've kind of discussed so far. We'll talk a little bit about duration of therapy in some of the next slides. But so I think right now, if I were to talk to that physician, I probably would ask them about, why the vancomycin, why the antifungal. The dosing was high too. She's obese, so it may be okay, depending on what your thoughts are about it. But she was getting the anti-pseudomonal dosing of 4.5 grams Q6 hours. If she was normal body weight, you might choose to do a lower dose. I don't know off the top of my head about obesity dosing for Durkin, but there may be opportunities to reduce the dose too. Let's go on to the next slide. So most of this we already discussed. The vancomycin is probably not needed. Durkin may be overly broad as well, although it is recommended in the guidelines. We didn't discuss the combination of vanc and Durkin here, but that could be used as a tool when you're talking to some of the community physicians about this, as we've talked about in earlier webinars. And then I think in terms of systematic solutions or issues with this, intra-abdominal infection presents a great opportunity for potentially order sets or algorithms or other things, because the guidelines are really broken up into whether or not someone has a community infection, whether or not they have a healthcare facility-associated infection or hospital-acquired infection, and you can really select your antibiotics based on that. So if you haven't taken a look at those or thought about including order sets dedicated to intra-abdominal infection, this would be an easy one where there's simple breakpoints for you that you could incorporate into order sets or pocket cards or something else for your physicians, or just share that with them when you're rounding with them and talking about different treatment options too. There's useful tables and up-to-date about this that kind of show what the recommended antibiotic agents are. And you may choose to be more selective about what you present. Those guidelines include carbapenems and some of the, like ertapenem in their community-acquired infections. So you might choose to modify some of those tables based on local data in terms of what your formulary has and what your recommendations would be. Usually for community-acquired infections, we're trying to save carbapenems overall. Next slide. In terms of treatment duration, there was a study in the New England Journal of Medicine in 2015 for complicated intra-abdominal infections, and they compared 4 days of antibiotics to 8 days. And you can see here in their primary and secondary outcomes and additional data that they included surgical site infections that were intra-abdominal and recurrent intra-abdominal infections too. They looked at site of the infection, if they had an extra-abdominal source, C. diff, and other things as well. And they found that short courses of antibiotics as short as 4 days were safe, and outcomes were similar to 8 days. So for this patient, when you're seeing them, even if you're not having a great time getting them to peel off some of these antibiotics, I think working with them to give them a shorter course duration would be one way to help from a stewardship perspective too. And this included ruptured appendix, like the case that we discussed as well. Next slide. So we highlighted this a little bit earlier. There's different classifications for these. These were based on the Surgical and Infection Society guidelines that were released a couple years ago. They classify intra-abdominal infections into low-risk community-acquired infections. So this would be perforated appendix, appendiceal abscesses, no risk factors for antibiotic resistance. They mention, they break it up into single-agent regimens and combination regimens. Even though the guidelines say that ertapenem and piptazo are okay, I probably would prefer something that would be a little bit more narrow for them. So something like ceftriaxone and metronidazole may be okay. I haven't done cefazolin since that's pretty narrow overall, even though that's mentioned. But you could use these to craft potentially tables or guidance to your local surgeons about what antibiotics you'd prefer. The fluoroquinolone therapy with metronidazole is a common one that's kind of stepped down. The fluoroquinolones, as we've talked about, have gotten beat up quite a bit. I'm not necessarily opposed to fluoroquinolones if you were to do it for a shorter course duration. My personal preference would probably be an IV third-generation cephalosporin plus metronidazole. And then if you were to step them down to PO afterwards, then I might explore the fluoroquinolones. The single-agent regimens, if you were to give this guidance to a community doc, I probably wouldn't mention the ertapenem one, since it tends to be broader and I'd be worried about inducing more resistance in the community. It also is more expensive too. Next slide. The next classification they have is high-risk community-acquired infections. So these would be high-severity illnesses, medical comorbidities, patients with healthcare-acquired infections or known colonization with MDROs. They choose slightly different carbapenems in this. The other carbapenems, meropenem, doripenem, and imipenem, have some enterococcal coverage, so that's why those carbapenems are selected over ertapenem. You'll see piptazo or zosyn still on there because it does have good coverage against AMP-susceptible enterococcus. And then combination regimens are the same as they were before, except now we're restricting our options to agents that would have anti-pseudomonal coverage because of that possibility that they could have a healthcare-associated bug like an AMP-C producer or potentially a pseudomonas, which ordinarily would be uncommon in the GI tract. They mention for high-risk community-acquired infections that even in this setting, antifungals probably aren't warranted for stable patients, but if you have somebody that's really sick in the ICU and on pressors, or if they have an upper GI source, then they may be more likely to benefit from antifungal coverage. And if we're worried about those people, we usually are going to give them an echinocandin instead of an azole. Community-acquired infections usually don't have issues with resistance and with azoles. When you start getting into these high-risk community-acquired infections, you also are going to be more likely to see cases where they might have azole-resistant candida too, so Candida glabrata or Krusei that would remain susceptible to an echinocandin. Having said that, though, once you know more information, if the surgeons go in and end up getting culture data on them, you should consider narrowing them based on the culture results. So if they don't have yeast that's identified from the micro data, you could probably step down their antifungal coverage if they're clinically doing better. And that could either be stepping down to an azole if you're having a hard time convincing them to stop it altogether, or stopping antifungal coverage. Next slide. So the next classification, healthcare-associated infection, is overall similar to the high-risk community one they mention in the surgical site infection guidelines, considering more enterococcal coverage, potentially ampicillin resistant enterococcal coverage as well, and then MRSA coverage if they have a history of that, or known or suspected colonization. But still, those are just consider. So you can see single agent regimens. We're still talking about non-ertapenem related carbapenems or piptazo. Between those two, I would still think piptazo is probably a more stewardship appropriate option. And then in terms of combination regimens, you're seeing the same thing. I probably would prefer cefepime over ceftazidime, especially if you're worried a little bit about staph. Ceftazidime gram-positive coverage is a lot poorer overall. And then considering antifungals is still the same recommendation. If you've got someone you're worried that they might have if your clinicians are worried about them having a lot of antibiotic exposures or not doing well, I would add an echinocandin like micafungin on as well. Micafungin is really well tolerated too, so you don't have to worry as much about side effects or other things as well. Next slide. So we'd be happy to entertain any questions related to that case. I'd love to hear if anyone here already has order set where your antibiotic recommendations for intraabdominal infections are stratified based on different categories like we mentioned here, or if you have any recommendations about antibiotic treatment duration as well, and if you think that those tend to work. And then, of course, we're always happy to hear stories about struggles, too. So Let us know if you feel like you're having issues with antibiotic treatment duration, and if you think something like this would be helpful. If you do feel like it would be helpful, we'd be happy to try to create something for this MASIC group. If you already have something that's useful that you've personally done, we'd be happy to share that as well. Looks like we've got some comments here. Yeah, how do you define hospital acquired? And then would meropenem work as well as ertapenem? We have a hard time getting them to switch over. Yeah, so defining hospital acquired can be challenging. Usually, if someone's admitted to the hospital for a period of time and we think that their intra-abdominal infection occurred during their hospitalization or was an associated complication during that hospitalization, we would consider that hospital acquired. I would be worried if you're talking about surgical site infections. Even if they come in from the community, those infections could still have drug-resistant organisms as well. So you may choose, until you know more information, to give them broader spectrum antibiotics because they are potentially at higher risk for multi-drug resistant organisms too. The next question is, would meropenem work as well as ertapenem? That's a great question. In our minds, I usually consider meropenem as kind of one step up, one that's slightly broader coverage compared to ertapenem. That's predominantly related to the additional pseudomonal coverage and enterococcal coverage that meropenem has. So meropenem will cover pseudomonas isolates, whereas ertapenem won't. The enterococcal coverage for meropenem is okay. It's not great. I would argue that Piptase is probably better, or imipenem is better. So I would view, if you're trying to create a hierarchy, I would view meropenem as a broader spectrum agent compared to ertapenem. So I would feel very comfortable if you were trying to discuss switching over from ertapenem to meropenem related to cost or formulary at your hospital, to tell the clinicians that that's not a step down. That if anything, meropenem is slightly broader. So I would personally feel very comfortable telling that provider that it's unlikely that they would get worse on meropenem if they're already getting better on ertapenem. Those are great questions. I hope that helps answer some of them. I don't know if there's additional questions that you guys might have as well. Is anyone using some of these, order sets specifically related to intra-abdominal infections at your hospital? What are your thoughts about treatment duration overall? What do you guys generally see? Yeah, this is a great question too. We've got one about clindamycin for intra-abdominal infections as well. Clindamycin probably we don't see it as much used for intra-abdominal infections at our hospital. Some people use it for the anaerobic coverage. You could get some MRSA coverage as well. If you were really worried about a hospital-acquired infection with clindamycin, you're probably going to miss a fair amount. At our hospital, you probably would be missing about a third to 40% of the MRSA isolate. So it's not great for healthcare-associated infections, and the anaerobic coverage for Clinda is not ideal too. So I wouldn't consider clindamycin to be kind of a first-line agent to treat intra-abdominal infections. We do see it sometimes for antibiotic prophylaxis in patients with allergies, in particular penicillin allergies. And in those settings, rather than using something like cefazolin, oftentimes we'll see clindamycin and aminoglycoside or something along those lines as well. So if you're seeing it regularly used in your hospital for an intra-abdominal infection, I would encourage them to use other agents. But before that, I would try to figure out why they're using it. If it's related to antibiotic allergies or intolerances, If they're using it specifically for anaerobic coverage, I probably would prefer them to use metronidazole, especially if they're using it in conjunction with another antibiotic. Or if they're using clindamycin in conjunction with other antibiotics and there's redundancies with anaerobic coverage, you could tell them you feel comfortable with the anaerobic coverage of Zosyn, for example, and that clindamycin is probably not necessary in that setting. We've got another question about ertapenem here too. If ertapenem is initiated in the ED and the patient ends up in the OR, do we need to redose preoperative? If so, what's the right time frame and what agents? That's a very good question too. We oftentimes will see patients come in with an infection and then they end up having to go to the OR, like the patient that we were discussing here. The half-life of ertapenem is quite long since it's dosed every 24 hours. One of the issues that we see frequently at our hospital is surgeons giving them extra doses of antibiotics. Some of these medications that we have, that we prescribe, including carbapenems, oftentimes place patients at higher risk of seizures if we're using higher doses of them. So I would discourage routine double dosing of antibiotics that would have particularly long half-lives. You should also talk with your surgeons and quality improvement committees to evaluate whether or not your timing of antibiotic prophylaxis and other things are how they're tracked. So for some quality improvement metrics and other things like that, places may care about time between antibiotic dosing and incision, so infection prevention gets involved there too, surgical quality improvement committees as well. So knowing what they're tracking and coming up with a consensus together, I think would be very important. So this is probably something where a more holistic approach where you get everyone together so that they're on the same page would be important. But in that meeting with them, I would specifically address concerns related to additional dosing of antibiotics that have long half-lives and potential harm that could cause. And some of these medications like ertapenem tend to be quite expensive too, so there may be opportunities for cost savings when you're looking at optimizing doses as well. That's a great question. If there aren't others, I think we can probably go on to the next slide. Erin, I think this is the start of your case then, is that right?
I think the next slide I was going to see before we went to the next case if anybody had any cases they wanted to ask us about, any volunteer cases. So I'll give people a minute to let us know if they have anything they want to talk about. And if not, we'll go on to the next case.
Yeah. Oh, and then I was talking so much, Erin, I hadn't gotten your input. Are there any additional thoughts that you have about the case that I didn't discuss? In particular, I think related to some of the questions that we had as well.
Oh, I just went to the next slide, so I can't see the questions now. But no, I think you covered things pretty well. Covered everything I would have hit. Yeah, I mean, the things I was thinking about at the beginning of the case we talked about with, if you're going to use an antibiotic, make sure it's dosed appropriately, right? So the vancomycin and her weight was probably not correct, but the bigger question is was it even necessary? Which I think you covered really well.
Great. Okay. Doesn't look like we've got additional volunteer cases. Also feel free to email them if you're shy and you don't want to ask on the webinar.
Yeah.
Or if you've got cases that bring up a systemic issue in your hospital and you want to have a one-on-one consultation, feel free to email us too at that mo.stewardship@wustl.edu. Great.
Right. And I'll say too, with this case that we're going to talk about next was actually a case that we got through our email. So this is a case from one of our participants. So in this case, this is a 73-year-old female who was recently diagnosed with dementia, and she comes into the hospital because of worsening agitation, confusion, and diarrhea. She does not have a fever, but she did have a white blood cell count of over 24,000. Her urinalysis was positive, and so urine cultures were sent off, and she was initially started on ceftriaxone, presumably for the urinary tract infection. So I'm going to kind of go through this case stepwise, but at this point, if you see any issues or have any concerns, or if there's data that you would be interested in asking about, go ahead and put that in the questions or comments here. I'll give you a little bit of time to do that. So in my mind, I'm looking at this patient and thinking, okay, she's got some baseline dementia, we know, and she's got some coming in with mental status changes and confusion. Her white count's pretty high. She does have a positive UA, and she's got that diarrhea. Yes, I see comments there, people asking about C. diff, and it does seem like a very high white count for a UTI. We did not get any history about previous antibiotic use in this patient. Also did not have any information here when the case was sent to us about if she had any other symptoms for that UTI. We don't know if she was having any of the typical symptoms, the frequency, the urgency, the pain, any, costovertebral tenderness, anything else associated with that, but that white count does seem pretty high. No report of a Foley. That wasn't something that was mentioned.
Yeah, I think these are great points, Erin. This is a particularly common scenario. Older patients that may not be able to report a good story to clinicians, so they are looking broadly for potentially a source of their infection. I mean, that white blood cell count is quite high. I'm usually reluctant to pin UTIs based on just urine testing alone. For elderly patients that you can't get a great history from, sometimes you're stuck with it. But in the back of my mind, I always think about asymptomatic bacteria. So patients can have abnormal UAs and have positive urine cultures, and the older you are, the more likely you are to have that as well. In the back of my mind, I'm debating whether or not this positive UA and urine culture is an incidental finding, and there's something else that's going on, like C. diff that people have talked about, or there might be something else that we haven't talked about too. The diarrhea could be related to infectious diarrhea from some other condition as well. So, which we also don't have a lot of information from. If this is, if she's at a skilled nursing facility or something like that. It could be some foodborne related infection as well, especially if you may have seen several cases of these or something like that in the meantime. Great.
Yeah, and also thinking about other medications too. Previous antibiotic use is important, but also is she on any other medications that could be causing the diarrhea as well? Does she normally take a laxative and maybe something else is going on and now she doesn't need that, or that could be contributing anyway? So. There's some missing information here.
And then from home or a nursing home, that's a great question about what antibiotics you'd want to give her too. Ceftriaxone may not
absolutely
be from a healthcare facility setting where you're worried about drug resistance. Great point.
Yeah. So what we do know is that her urine culture came back positive for VRE, but it was ampicillin sensitive. So the team switched her to ampicillin, but her white count continued to climb, and she continued to have diarrhea. The diarrhea was significant enough that they started her on loperamide. So, curious, I'll give our participants a chance to respond to what they think about that. Oh no, yes.
These are great points. Yeah, I think oh no is the best one. Yeah, this doesn't sound good, right?
Yes.
VRE, it's rare for it to be susceptible to ampicillin, but it can occur. I don't recall what our percentage is here. It's probably less than 10% of VRE isolates are susceptible to ampicillin, but occasionally we get lucky and it is. But it makes me a little worried, right? They have this initial diagnosis and they're treating them with it, and they're on antibiotics that are directed towards the pathogen, and then they're getting worse, it sounds like, right? They're having diarrhea and their white blood cell count is going up.
Yeah.
So usually that's a time where the clinicians should try to reassess what's going on and say, did I pick the wrong antibiotic? Is it some other condition? Maybe it's a source control problem that we're not aware of. If they've got some large abscess or something along those lines in their abdomen, or maybe a prosthetic abscess, and they have a positive from VRE, and they have a positive urine culture related to that. But in order to treat that, antibiotics alone, especially if it's a severe abscess, may not be working quite as well. So these are great questions. What do people think about the loperamide? Was that a good choice? Bad choice?
Yeah, that's what I was going to bring up. That's a surprise that they would start that without, at least I think, without looking at the stool first. That's definitely a red flag, I think.
Yeah. Great. Oh, yeah, stool
Right.
culture, I think that's great. Yeah, so going back to the drawing board and trying to reassess, right? They're still having diarrhea. Maybe it's something else. It's not related to and diarrhea and UTI doesn't quite fit. Usually we're looking for a single thing that explains all of their symptoms, if possible. It may suggest that there's two separate processes going on. That's
right.
Great.
And that white count was over 24,000 to start with, and it's still going up. So that's a pretty significant white count, I think, for just be thinking that that's a UTI.
So I think what this also brings up an important point too. When this is a challenge because from a pharmacy interaction with the clinician standpoint, you're starting to get more into establishing a diagnosis and other things, and trying to think about the differential diagnosis as well, rather than just trying to optimize the antibiotic selection. And some clinicians can feel like that's kind of infringing on their autonomy a little bit. Erin, how would you approach talking to a clinician if you're worried that they need to go back and question their diagnosis and treatment plan?
Well, I think humbly is an important point, because there have been times where, even when you ask a question as nicely as you can, people turned around and said to me, well, where did you get your MD? And, I hate that response, and it makes you feel really bad. But so I've said this before, I always just ask the question. And in this particular case, if they hadn't gotten a stool sample at that point and their white count's going up and their still having diarrhea, and it's significant enough that they're trying now to treat the diarrhea, just asking the question, say, hey, I noticed you started loperamide on this patient. Her white count's really high. I'm really concerned that there could be something else going on. Have you thought about a stool culture? And then see what they say, and hopefully they'll get one at that point. And if not, you'll have to figure out a way to respond to whatever it is that they say. But just asking that question, like, have you considered this? Is there something I'm missing because this, I can't make this picture make sense. But yeah, so in this case, not surprisingly, they were eventually found to have C. diff. And so I think there were lots of things that were potentially overlooked, or lots of warning signs that were sort of overlooked along the way in this particular case. So if we go through the discussion of this, our choice of agents, we talked a little bit. I think the loperamide is really interesting. Generally, when you're thinking, it sounds like they did not know they were treating C. diff when they started it. And generally, historically, everybody's been taught, don't use loperamide, don't use antimicrobial agents in somebody that's got C. diff, because you don't want to increase the exposure to the C. diff toxin, right? You want them to sort of let that go. But the newest C. diff guidelines, which were put out about a year ago, they certainly don't recommend loperamide, but they do say that there's not really evidence that it causes harm. And if you go back and look at reports of patients that have had C. diff that have been treated with loperamide, as long as they got antibiotic therapy in a timely manner, they did not have worse outcomes with the loperamide. There's no randomized trials. This is all case study information. But it's interesting because, when I was in school, it was sort of like, well, that you definitely don't want to do that because you're going to make the patient worse. And there's actually some folks out there that have an opinion. There's, again, not evidence to support this, but have an opinion that, sometimes the complications from dehydration, if the C. diff is severe enough and they're having, a lot of diarrhea and they can get dehydrated, that sometimes those complications might outweigh the benefit, or might outweigh the risk of using the loperamide. So maybe there would be some benefit there. But the guidelines just say that as far as using loperamide in somebody that's got C. diff, that we don't think it causes any harm, but there's no recommendation to do it. So I thought that was something interesting. And in terms of, you look at the antibiotic de-escalation, they went from ceftriaxone to ampicillin. So that was a de-escalation, and there was spectrum there. So from a stewardship standpoint, maybe that was a win. But when you think about, in this particular case, was it really necessary? Did she have a UTI and C. diff, or was it really just C. diff all along, and she happened to have asymptomatic bacteria, which you wouldn't need to treat? And we know that in patients that have C. diff, exposure to antibiotics is one of the biggest risk factors that is modifiable. And so if they don't need them, you don't want to expose them to additional antibiotics. And in patients that have C. diff, if they are exposed to antibiotics while they're being treated for C. diff, or sort of in a short time frame after, that increases their risk for recurrence. So antibiotics, unless you know that you're treating something, giving antibiotics to somebody with C. diff can actually increase their risk for recurrence. So that's something that you want to be careful about. And in terms of systemic issues and solutions, Mike mentioned asymptomatic bacteriuria versus UTI. In this patient, it's hard to tell. Just having somebody come in with mental status changes, even the mental status changes and the positive UA, doesn't necessarily mean UTI if they don't have systemic signs of infection. She had a white count, so that makes things, and she had a pretty significant white count, so that makes it a little bit harder to tell. But it seems like the diarrhea part of this picture was just completely overlooked in the beginning. So there were
That's a great point,
some
Aaron. I mean, the new guidelines for urinary tract infections
Yep.
or asymptomatic bacteria mention that patients with delirium, um, it's complicated assessing patients with delirium and likelihood of urinary tract infection. But in reality, probably the most common thing in that setting is related to polypharmacy instead of urinary tract infections. So it's something to keep in mind. That's another thing that's hard to question the diagnostic skills of the clinician that you're talking to over the phone. But if you do see a lot of opioids or benzodiazepines, benzos, or other things that may be contributing to delirium in some of these patients, cleaning up their medication lists while they're in the hospital could sometimes help too. So that's not necessarily a traditional stewardship thing, but it's something that you may ask clinicians when you're talking with them to say, hey, I know that they're here for confusion, and we think it could be related to the urinary tract infection or something else. It looks like, or do you think that they're on any other medications that could potentially contribute to confusion too? Would these be beneficial for them in the long run, or what are your thoughts about cleaning up some of those things? There's a lot of push by the geriatricians, especially in older patients, to simplify med lists because polypharmacy is such a common issue.
Absolutely. Sometimes that's difficult in hospitals that use hospitalists because sometimes the hospitalists are reluctant to change some of the long-term, more maintenance meds, but it's still worth bringing up because we know that polypharmacy is a big problem in our elderly population and certainly is not without risk. One of the things I think is really great about the newer from a year ago C. diff guidelines is they actually really emphasize antibiotic stewardship. The way they emphasize it doesn't necessarily directly apply to this case, but they talk about they have a lot of data and a whole section in there about antibiotic stewardship and how when there's a C. diff outbreak that antibiotic stewardship is one of the more effective interventions, notwithstanding all of the environmental things that everybody must be doing. But it's an intervention that you can make that can actually have an impact on your C. diff infection rates. And they have a whole table in the guidelines that reviews some published literature, mostly reports from hospitals about interventions that they have done with antibiotic stewardship and restricting antibiotic use when they've had C. diff outbreaks and the effectiveness of that, how they've been able to reduce antibiotic rates in their targeted antibiotics and oftentimes in overall antibiotic use as well, and then how that contributed to a reduction in C. diff rates. So if you're looking for literature to show your administration to help support your stewardship program, the C. diff guidelines is one additional piece of literature that really emphasizes the role of stewardship in C. diff, which I think is nice. In this particular case, it's different, and I'm one of the things that I thought was interesting to think about was how in this case could stewardship have helped, because for a lot of hospitals, the antibiotics that she was on, just starting a patient on ceftriaxone may not get them a stewardship review, depending on how robust your stewardship program is. And so what in this case would have gotten the pharmacy involved or flagged the stewardship program to make an intervention? And I don't know what the answer to that is. Some hospitals I think are reviewing all antibiotics, and if you're able to do that, that's awesome. And you may have been able to catch that and question that earlier. For others, it wouldn't necessarily be a stewardship thing, but I think when loperamide is started in patients that are, especially in patients that are receiving antibiotics, that might be a flag of something for pharmacy to look at, and then flip that over to your stewardship person. And I just put on here in the next slide here the links to the guidelines. The asymptomatic bacteriuria guidelines were just updated last month, and the C. diff guidelines there that have that part where they highlight stewardship, they were updated just a little over a year ago. So those are available online. And if anybody's we've got our conference feedback poll up, but if anybody has any questions, comments, anything that they want to talk about further, you can raise your hand and we can unmute you. And, you know, if you have cases that you want to hear discussed, send them to our mo.stewardship email, and we'd love to hear from you guys. And if you want to just talk about your stewardship program, I'd love to talk to you guys about that too. Just send me an email and we can set up a time.
Great. Thank you guys very much. If you have additional comments or feedback about what materials we could create to make your lives easier too, we'd be happy to work on those as well.
All right, thanks everybody for attending. I'll leave this last slide up for a little while just so everybody can fill out the feedback for us. Thanks a lot.